what I'll try to do is answer questions that hopefully are on your mind, so it'll jump from one question to another. Sorry if it won't be as kind of refined and outlined as typically a talk would be. So first we'll talk about ureteroscopy. And so we talked a little bit yesterday about how what really guides patients' decisions is success rates. And we've thought that ureteroscopy does really well. In fact, when we were having our discussion with the audience, I said, ureteroscopy is 90% success, but is it really 90%? So when we look at Peggy Pearl, who's an active basketer, tries to clear out all the fragments that she can see, unfortunately, outcomes aren't as good as we expected. Overall, 55% stone-free rate when she gets a CT postoperatively. In particular, when there's multiple stones that total more than 10 millimeters, so this is where we're starting to extend the indications for intrarenal surgery with ureteroscopy, success rate is only 37%. In contrast, when you're in the ureter, success is pretty good across the board, irrespective of where the stone is or how big they are, around 80%. So yes, ureteroscopy remains a mainstay for ureteral stones, but perhaps we need to reconsider the use of ureteroscopy for the extended indications, the medium to large stones in the kidney, when we use CT as the outcome. So when we compare that to how one might do with shockwave, there are ways to combine stone-free skin-to-stone distance and Hounsfield units to identify those patients who might have a 90% success, where the skin-to-stone distance is short and the Hounsfield units are low. And in contrast, we can pick out those patients who would be better suited with ureteroscopy as opposed to shockwave. Now, we had a bit of discussion in terms of what you would like to do if you had asymptomatic stone, and there was some discussion about ureteroscopy versus shockwave. I had a good discussion with Richard afterwards, and certainly our techniques differ, which I'll talk about a little bit later in the talk. And it might be that because he doesn't use a sheath, he doesn't see the types of ureters that sometimes I'll see after ureteroscopy, and that might be why there's a certain flavor towards ureteroscopy being superior to shockwave, because certainly shockwave does carry risk in terms of contusion and hematoma. But really, when we look at why patients choose what they choose, it's a risk-benefit ratio. How bad am I going to hurt versus what's the likelihood of success? So if you take the likelihood of success for ureteroscopy and subtract it from shockwave, if the difference is greater than 50%, everyone chooses ureteroscopy. No one's going to choose shockwave. In contrast, if the difference in success is only 25% or less, then almost everyone will pick shockwave. So while we look at it from perhaps a different standpoint of what's the stone-free rate, oh, it's better with ureteroscopy, let's do ureteroscopy, the patients ask the question, well, how much better is it? Oh, it's only 25% better. Can I still do ureteroscopy if it doesn't work? Yes. Okay, well, let's try shockwave. So it's really when it gets down to here, 25 to 50% where it's split. About half the patients choose shockwave, half the patients choose ureteroscopy. They'll say, doctor, what would you do? We have to turn it back to them and say, well, what's more important to you? Getting the stone out with one surgery or minimizing your risk? Next question, dusting versus basketing. The dusters say, well, I don't need a basket, a wire, a sheath, or a stent, so I'm going to save money because I'm using less equipment. The surgery will go quicker. But most of the dusting studies use either a high-watt laser, Moses software, or now the thulium laser. In contrast, the basketer says, well, I save money because less higher stone-free rate. Even though I'm using a basket, a wire, sheath, a stent, there will be a less need for a secondary procedure. In terms of stone-free rates, one study we did with the EDGE group showed that there was a 31% chance of residual fragments with dusting compared to 9% with residual fragments. Now, there have been subsequent studies where we followed the patients longer. Some of those things show, because it's a relatively small sample size, I think, we don't really show a difference in terms of stone growth or long-term follow-up, but in the short term, there's no question that stone-free rates are higher. This is another study from Germany, from Hamburg, where Margit is from, and it again showed with KUB on post-op day 1, stone-free rates higher with basketing compared to dusting. Now, how small do the stones need to be? We talked about this a little bit during the critique with Benji, and this is just Nakata's study that showed that the upper two graphs here, this is stone-free, this is 1 to 2 millimeters. So the 1 to 2 millimeters fragments do just as well at 8 years when it comes to looking at the need for a second surgery. So the stones need to be smaller than 2 millimeters. Bigger than 2 millimeters, you're going to find that they're going to have a higher risk of needing a second surgery. Question number 3, thulium versus holmium. My hospital's looking into buying one. The advantages of thulium: smaller laser fibers, so eventually maybe smaller scopes. Even if you use your same scope, you'll have better irrigation with the fiber in place. You might have better deflection. Lower energy, higher maximal pulse repetition. What this translates to clinically is that there will be less retropulsion of the stone as you treat it. So the laser fiber will be in contact with the stone for a longer period, and you'll have a faster ablation rate. The second thing is that it'll ablate the stone more rapidly, irrespective of the type of stone: uric acid, calcium oxalate, and monohydrate. Irrespective of the composition, ablation rates will be faster. You'll also have less degradation at the tip, because the faster you can go on the pulse rate with the lower energy, the less degradation at the tip, so perhaps less risk of damaging your scope. And this is just some work from Traxxer showing that yes, the displacement is less and the average volume of the ablation is higher when you use the TFL compared to all the different modalities that you could use with the holmium laser. Again, some more studies from Ben Chu in Vancouver supporting that whether you're fragmenting or dusting the stone, you may be able to do it more efficiently, but really the main difference will be if you're a basketer, if you're a duster compared to if you're a basketer. But Nakata recently presented at the World Congress of Urology, not published yet. In an RCT, he showed that there was no clinically significant difference in stone free rates when you compare thulium to holmium. And I think all of you have seen the black box warning from Olympus about the charring of tissue. So essentially, and then the third thing is, people who really love the thulium will say it won't break up every stone. So the main question is, can you afford 2 lasers? Or do you need to only buy 1 laser? If you only can afford 1 laser, it should be the holmium, because it'll work for every stone. If you can afford to have a thulium and a holmium, and everyone says, well, why not have a machine that has both, which the companies have heard, but they haven't developed yet. If you can afford to have 2 lasers, then having the thulium for your larger renal stones probably makes sense, but having the holmium for the ureteral stones is going to be important to avoid charring of the ureter. Question number 4, is it? Sheath or no sheath? So the main reason I use the sheath is to keep intrarenal pressures low. You may have heard of the Litho Elite disposable scope. It's a scope that will enable you to measure the intrarenal pressures while you're doing ureteroscopy. It was FDA approved yesterday, so I suspect your Boston reps will be in your office next week to tell you a little bit more about it. But really, it's going to be fantastic to be able to measure intrarenal pressures. Not that I can tell you what you should do in terms of setting your pressure, but hopefully it'll enable us to define what intrarenal pressures are going to prevent injury during ureteroscopy. Well, this is the type of picture that I sometimes see after ureteroscopy, and this might be why many of us raised our hands for shockwave, but those who don't use a sheath perhaps say, you know, I don't see this, so I'm more favorable for ureteroscopy. So one of the questions we asked, well, does it matter what type of sheath you use, flexor from Cook versus Navigator? No. Irrespective of which sheath we used in this RCT, 13% of the time we saw a muscle, which would be a level 2 injury, and 8% of the time we saw fat would be a level 3 injury. These numbers are a little bit higher than what Traxxer reported, so perhaps we're pushing a little bit harder than him. But then we combined our series with his series to look at the 59 patients who had a grade 2 or grade 3 injury, because the next question is, well, does it matter? And the answer is no. At 3-year follow-up, the stricture rate's the same, 1.8%. It was the same as the other patients who had no injury. So based on this, we think that if you leave a stent for 2 weeks, when you see something that looks like this or this, you can mitigate the risk of developing a long-term stricture. Well, I said maybe I'm using more force. How do you know how much force to use? This is a group from Korea, and Dr. Clayman is developing a similar device. You attach it to your sheath so you can actually measure the force. If you keep the force below 600 grams, you can avoid a grade 2 or grade 3 injury. Interestingly, they show that at the UVJ, when you look at patients who had an alpha blocker or were pre-stented, the amount of force was lower. So an alpha blocker is an effective way to decrease the amount of force to get either your sheath or your ureteroscope in. So we are pre-medicating all our ureteroscopies with an alpha blocker for a week before ureteroscopy as part of our care pathway. But the other place where the ureter will be tight, and here it's less forgiving because here you're more likely to see fat, is the proximal ureter. In the proximal ureter, the alpha blocker is not protective, but pre-stenting is. So a little later we'll come to some discussion about whether you should stent versus do ureteroscopy, and in which patient to consider it. Proximal ureteral stones would be a place where you might consider pre-stenting, whereas distal ureter you probably don't need to. But an alpha blocker is good to pre-medicate patients with before any ureteroscopy. So the next question is, should I switch to a disposable scope? And first I'll say, I'm a dinosaur. I still like fiber optics because I think fiber optic scopes give you better deflection, better maneuverability, better resolution. But if you are going to compare apples and oranges, you got to pick your orange. And I think the best orange are the Wolf scopes. The Wolf scopes have the best resolution. So when you read a paper comparing a disposable scope to a non-disposable scope, it's important to look at which non-disposable scope are they comparing it to. Now this is just to show you that it's hard to keep up. Every week there's a new disposable ureteroscope, so we can do a study looking at resolution, deflection, maneuverability, but next week we'll have to repeat it because there's a new scope to look at. Essentially, most of these scopes are good. Some of them are better than others. And it'd be hard for me to say that LithoVue is the best because I thought it was the best last week, but maybe there's something better this week. I think the key is cost. And for cost, there have been a few studies, this one's from Mayo, that says that if you do more than 100 cases per week, then it's probably better to use a reusable scope. Less than 100 per week, it's probably better to use a disposable scope. UCSF says the cost is the same, whether you use a reusable or disposable scope. The cost of the procedure is around $2,800. So the cost is going to depend obviously on your center. How much can you get the scope for? Which scope are you buying? What's your cost of sterilization? Now, how many of you threw your towel on the floor this morning? You're not going to say. How many of you hung up your towel because you're going to use it again tomorrow to save water? So do you know that depending on how you sterilize your scope, you're going to use 6 liters of water to sterilize one scope, whether it's your cystoscope or your ureteroscope. So we think a lot about, well, it's a disposable scope, it's going to add to the environmental issues we're facing, but water is going to be a big crisis for us. So I think one of the things to consider will be how much water does it take to re-sterilize scopes, and that might end up being the driver in the shift to disposable as opposed to reusable. Now, what to do about the asymptomatic stone? Benji covered this paper, so I won't talk about it a lot, but just to emphasize what he said, it was 3 to 4 millimeter stones. Because the question is, should you be doing bilateral ureteroscopy or staging? The Michigan study said that if you have to break up the stone, the chance of complications is going to be higher if you treat both sides at the same time. So it's better to stage it. So when you read this study, don't think that, oh, there's a 10 millimeter stone on the other side, I need to take care of that now. It's better to stage it than to do it at the same time because your complication rate is going to be higher. Now, if you look at this, the conclusion that you need to treat the other side, we come back to Benji's question of the 5-10-5. So here, 4 years, only 25% of patients in the observation needed surgery. So divide that by 4, that's roughly about the same as his 5% rule per year. So if we're saying that you can wash those patients, maybe we don't need to take this New England Journal of Medicine and say you have to chase that 3 to 4 millimeter stone. So just a different spin on the same paper, questioning whether the conclusions are accurate, emphasizing the importance that it's small stones they're talking about. Stenting versus not stenting, this is a meta-analysis from Vernon Pace, just to emphasize that stented patients come back to the ER less than unstented patients. Unstented patients were more likely to have an unplanned medical visit, even though their operative time is shorter, there's less dysuria. Stent emission may be associated with a higher risk of coming back with pain. The next question is, okay, if I'm going to leave a stent, how long? RCT, 3 days versus 7 days. It's best to leave it at least more than 3 days. We don't know if 5 days is better. I take mine out at 5. But 3 days is too short. If you take it out at 3 days, they're more likely to come back to the ER. They're more likely to come back with flank pain. String versus no string. When you look at patients that come back to the ER, 57% of the time it's related to the string. So 46% come back after they pull the stent out themselves at home. 11% come back because the stent came out before it was supposed to come out. So typically I don't leave a tether and do an in-office cystoscopy. This is just another thing, combining the two things, string versus no string, and how long to leave it. We see that if you take it out at 2 days, a third of the patients are going to come back. 3 to 7 days, fewer patients come back, but more patients come back if you leave a string. So essentially, I think one should be aiming maybe for right here. 3 to 7 days, no string, only about 7% of patients are going to come back. That's the lowest number out of all these numbers here. Alpha blockers, stent pain, 12 RCTs, helps decrease pain, improve urinary symptoms, improve general quality of life. Just to add to that, give oral Toradol. This was a RCT we did, scope study, that shows that you can, instead of giving oxycodone, you can just give Toradol and you'll have this lower pain scores compared to using oxycodone. Important to remember that patients have pain after stent removal, so if you look in to take the stent out, you see a fair amount of edema around the UO, give them some Toradol to take for a few days, because otherwise they're going to come back with more pain, and reassure them that it's normal to have some pain for a day or two, but it'll get better. Nice study from Manoj J that says if you measure the Hounsfield units at the underneath the stone, if that number is greater than 27, it's a sign that the stone is impacted. So if the stone is impacted, this would be the type of patient where you'd probably want to stent the patient as opposed to try to do ureteroscopy at that setting. This was a study from Japan where they characterized things a little bit more, and what their endpoint was what was the likelihood of having a grade 1 or grade 2 injury. So what you're really worried about is this red here when they use the Traxler classification. You see that if you see this polyp, just proceed. You can take the stone out because none of these patients get an injury. If you see edema, you might as well proceed because you're going to get an injury whether you place a stent or don't place a stent. So here, staging the procedure with the graphs on the right, or if you stage it, the graphs on the left, or if you do the ureteroscopy, it doesn't matter. Either way, you're in a bit of trouble because there's a likelihood of getting an injury. The place where it makes a difference is if you see this. If you see an intrinsic stenosis, place a stent, come back another day, because you're going to be able to mitigate the risk of having an injury if you pre-stent the patient who has an intrinsic ureteral stenosis below the stone. And then this is just the ORIS device that we talked about a little bit during the PCNL, emphasizing that I'm not really sure how helpful this will be for ureteroscopy, but it will be a very good device to help you with percutaneous access if you'd like.